always looking for making the most difference for the people least likely to take up a service. If you just go out there and promote something, the people who understand, read and are motivated will take it up, and the gap absolutely widens. And you don't make any overall difference to your outcomes at a borough-wide level.
Yeah, we had one lady and she was like, oh no, in our family I don't have no cancer history, we got more heart disease problem, my dad passed away, my granddad passed away in heart disease, like, so if there's anything going on in the heart disease, any program, then I'll be interested to join, but no cancers. Yeah, then finally after 3 months she found that she's got a lump on her pits, and she was telling her, oh, you do the cancer, you know the symptoms, can you help me? And she was like, oh yeah, you should go to your doctors. And then she found that she's got breast cancer, but it was very early stage and she get recovered.
In the rooms each day, people were opening up for the first time about stuff, and there were people crying, saying, I've never been able to speak about this before. And that was so powerful. And all the other things that we're trying to achieve with this project in terms of getting people to understand what the NHS models of health care are for psychological health, and that they're not kind of right or wrong as opposed to the maybe different models the community has, but that's what they are, and if they're things that you can do to support people, you could really see people getting that and going, okay, so my GP can help me with this strange behaviour that, you know, my ageing mother has got, or something like that. And yeah, people were really talking for the first time about things that they would have kept very secret before. Really sense of empathy, particularly in the film event. It's a big event in the room, people kind of clapping and cheering, and you know, it was a very moving, kind of powerful event.
My doctor say you have to go to an exercise is better for me, and this way come down, and I feel it's a bit light when you go to exercise and come back to exercise. I feel better, and this way come from to every time coming to exercise. Yeah, we change diet as well. We always try to light food and salad and sort of thing, fruit, everything. Already come down my weight about 5 stone.
It was really about sort of anecdotal stuff. First of all, at the time, people saying, well, I didn't know that, and I'll go back now to my GP and say, actually, I think my father does have some kind of dementia, and I've been fobbed off before.
It's called the Healthy Foundations segmentation tool. That segments really, really broadly. It's just 5 categories. About 20% of your population will be what we call health-conscious realists. Maybe 15–18% would be what we call unconfident fatalists. And a similar size group would be live for todays. And then you also have people who are balanced risk takers. You know, they'll work out rationally whether they're going to do a health behaviour or not. And then you also have some hedonistic people who just say, well, you know what, I'm only here and I'm going to enjoy myself. Now, when we did that research in East London, so it was Tower Hamlets, Newham, City and Hackney, Waltham Forest, I can tell you in Tower Hamlets, 41% of people were unconfident fatalists, so more than twice as many as in the national population, and 41% were live for todays. Whereas if you run a focus group, the chances are most of the people around the table are health-conscious realists. You know, the people who are going to make those changes and do the things you want them to do.
I'm from Bangladeshi community. So there's lots of groups in Tower Hamlets, but they don't know about the service, you know. Lots of things going on in Tower Hamlets, but they don't know. They don't know because of the diverse community. Some people they don't have access, like they don't know how to communicate. This is the main problem. You know, lots of people elderly age, like if they get invitation for bowel screening. They don't know how to use the tools, and that's why they don't turn up for the invitation. Also, like for breast screening, some people they do get invitation, but they're not like familiar. They don't know. They don't get encouragement from other people, family members, to attend.
In Tower Hamlets, we got diverse background, people coming from different countries, like we got Asian, Bangladeshi, Somalian, Black Caribbean, Vietnamese, Chinese. So people with the different cultures and finding what are really problems. As a result, I find there is always this misunderstanding, something is going on in the community, and people are not like very focused what they're getting benefit, and certain issues, like there's got lots of issues going on as well. So people not aware of them, they don't know where to get those supports or whether they need to find their informations. Each community have got different cultures, different beliefs, so it's always like hard to get along with the people's their beliefs. So, because cancer awareness, we find that people they got different belief on each cultures. Some people are really open to talk about. Some people are not very sure if someone's got a family, and someone's got they got bad experience with the GPs, or the family member had a bad experience with GPs. And when last time we went to see one of the Somalian women who's like over 60 plus, they was really believe on their God, and they just think it was all up to Him. What will happen. You can't stop it. So it's like kind of belief, and we respect their belief. It's hard to get into such issues, and when there's people got different belief and different opinion.
And I'm not suggesting all ethnic minority people can be lumped into one group. So in Tower Hamlets, we've got a growing younger population who are becoming diabetic much earlier. Their needs might be very different to the older generation of ethnic minorities. So it's about understanding the kind of nuances within our population and their specific needs. So we're looking at, do we need to look at a different type of education self-management for younger population who might be working, who might have childcare needs, etc., i.e. do we want something web-based, app-based, or because they're much more able to use those types of tools, where the younger population, especially amongst, for example, our Bengali community, tend to be reliant on the oral tradition. So it's about really understanding what is the need, how do people engage with the system, and tailoring it as much as possible.
So all of this work was really to say, what can we do to just kind of move from this plateau where we've got to as good as we can get using all the interventions with evidence. There's something else and we don't know what it is, and the best thing to do would be to find out from people themselves, what is it that stops you coming forward for screening? What I really liked about it was incredibly accessible by people who won't normally respond to traditional methods of research. So, and traditional, I'm talking about interviews, surveys, even focus groups, things where you have to get someone to come along, or where you have to get somebody to answer questions in a formal way, certainly where you have to get someone to read something. What this seemed to be, when I saw it in action, is first of all you went to where the people were, so that's a huge plus. Secondly, it's fun. So the people who you're asking to participate, they can get a lot of enjoyment out of showing what they think and feel, and it might make them think about things they hadn't thought about. And I think thirdly, it's absolutely anonymous, because people put a sticker on or they draw something, but there's no record left that this person or that person made that comment. So the researchers can look and they can see maybe how many were men or women, or which particular venue that information came from. And often, that's good enough. You get themes out of it and you might want to go and pick those up. And I felt it, so suited a community where you've got people who've got low levels of English, written and spoken English, low levels of health literacy, low levels of time to stop and commit. So it's not that they don't care, but people have very busy lives, a lot of other priorities. They've often got children around their feet, they've got older people they're caring for, and they don't have a lot of time in the day to give up. Our social marketing research has shown us that traditional leaflets, posters, even TV advertising is not particularly likely to change behaviour and knowledge around cancer symptoms for the local population, that we were more likely to influence people through engaging with them through peers within the community. So skilling up people in the community as peer educators, we think, has a greater impact.
The background thinking to a lot of this is about the important ways that communities will engage better with other communities that look like themselves. So, very long time ago, I was working in South London. I was talking to a group of young men in a music-based project in Battersea called Sound Minds, and it was for people who had mental health problems. I was interviewing them and just asking about their experiences of local mental health services and things. And I'm a white guy, but those days wasn't in a suit. The majority of the people in there were young black men. And after about 20 minutes, I had a kind of tea break, and we were just chatting, and somebody said to me, "Hang on a minute, you don't work for the council, do you?" And I said, No, I've explained that already. I work for an independent charity. And they went, "Oh, well, we can forget all the other stuff we've been telling you." So we got a next bit of the meeting. They were telling me a bit more detailed stuff, and the quality of the engagement was really good. Then they had another coffee break, and the guitars were brought out, and I played guitar as well, so I started playing guitar. So there was a further level at the next session of honesty. So, well, he's kind of, not only does he not work for the council, but then that second level of, he plays music as well. That's something about them seeing me in a different way. The quality of the information you'd get was so much better. So it was starting from that kind of point. It's about people talking to each other is very different from having people standing up and kind of extracting information.
Yeah, well, you see, someone friend tell him to come in here, and I join it there. Someone friend tell me to go to what they call Tumby Hall. I go there as well. I looking for exercise. And everyone is a friend. I told him to someone come in there. There's two of them, they come and join there as well. That's why we recognize each other. I can see they go there. You can go to exercise there. You got diabetics or any other problem. They give you good help.
We got a few people that's already doing social care in universities, A-level students, they want to go into health sectors. Plus we got some few mothers as well, they just wanted to work in community to help the community. Most of our volunteers are local, they're from Tower Hamlets. We advert in the newspapers. Also we got websites, people are responding. Plus we're running lots of projects. We got diabetics preventing maternity meds, and now we're doing cancer awareness. At the moment people are more interested in doing the social care, doing cancer awareness. We just train them, support them so they can facilitate and run sessions in public. We work for every community. So all of our volunteers, they speak fluent English, and we trying to approach all community peoples, not only restricted to the Bengali or English. We do for the white communities, Black, Caribbeans, Chinese. So we do have volunteers from the different background as well, so they can represent their own community.
They were all from local community, and particularly with this project we were able to pick volunteers who knew the local communities and could engage, and it's very important. One of the kind of key messages for this kind of way of working was that because there was a lot of stigma around these kind of issues, people seeing people who they felt had something in common with them, whether it be in terms of culture or faith or something similar, that was just really helpful. We were thinking, well, if somebody like that thinks this is a safe conversation for us to have. So yeah, we're very careful it was from the local community and reflected the demographics that we were working with. We also host the volunteer centre, Redbridge, as well, so we did that internally. So it's fairly straightforward, just through our own volunteer centre. Nasima Patel, who was the project worker, was able to translate herself for most of the languages. In some cases, some of the participants were able to do it. There's enough people speaking enough common languages that they could do it. Certainly some of the things that this project has done is look at the impact of the translators. So we know people have given 5-minute answers and the translators given the 2-word translation. But in this instance, because Nasima was able to do it herself or in combination with members of the group themselves, and there was enough people to double check, and I suspect on occasion would have said, that's not quite what I said.
Our ethnic minority patients will often say, we like the clinicians to come to us in our setting. So they'll say they like them to come to the kind of community programs, because the way they describe it, if you have a guest and they come to your house, you're very hospitable, you're open, you ask questions, you're more relaxed. Whereas if you go to their house, i.e. in their setting, they feel much more weary, much more restricted almost. And I imagine that plays into a lot of how people use primary care and how people use community services and the types of people who might.
Some of the communities, they understood what we were saying and where we were coming from. They were able to have that shared discussion. But they also quite wanted somebody with a white coat and a title like a doctor or a professor to be there as well. And so we were able to work that really nicely, where it was our event and it felt like the community's own event. But then on occasion we would bring in somebody from the NHS with a impressive sounding job title, and that was really valuable as well.
We're kind of looking at how do we support self-management for people with long-term conditions. And at the moment, we're devising pilot projects that have been co-designed with CCG, voluntary sector and statutory organisations. So we had quite a close invitation to voluntary sector providers. We specifically chose organisations that we know have a long history of delivering and working with the PCT or the CCG. We invited statutory, i.e. our COPD, respiratory services, our diabetes service and various other services that we know manage long-term condition patients, put them in a room, and then we said, right, you've got a couple of hours to come together, discuss what you feel are the needs of the patients that you see around self-management, the purpose being to keep people out of hospital, treat them, support them, help them self-manage in the community. Come together, devise proposals. We reviewed what they'd produced, asked them salient questions around, well, how would you do this? Why this cohort? Why this many? Just to prompt their thinking. And they've done several iterations. We produced a proposal performer, more to kind of prompt them to focus their thinking. What quality outcomes might there be? What clinical outcomes might there be? What are the patient experience outcomes? You know, how might you demonstrate this? All of those types of questions. What would be the investment that you require? Why? Break that down. What would be your project plan, timescale? What other resources might you need? What might be the challenges you anticipate and how might you overcome those? Those types of questions. So the co-design is very much they're doing the thinking, we're doing the guiding. And we review it, and it's not a bidding process, it's more around let's shape it and let's learn through that process. I think where the gap has been is the patient involvement element, but we're hoping that as providers themselves, they're going away and using their learning and expertise of engaging with patients and even engaging with their own patients to shape some of this.
So I think biggest criticism is going to be says, oh, GP need to be more over than you coming to us. People always complain about the GPs. They have family, friends, and they have a bad experience with the GPs. We had one client, she had some burning pain plus coughing, She went to the GP, so they given some antibiotics. It didn't completely gone, but it was settled down. So she went after 3 months. Again, she had problem. So they given antibiotics. So it's like going to the GPC checking is taking quite long, rather than the doctor refer her for chest X-ray or for a scan. So after more than 3 months, then doctor refer her for a scan, and then they found that she's got lung cancer, and it was in late stage, and it's been spreaded. So she given a time limit. So it was very sad to hearing those stories, because GP, they got lots of patients, so they might not taking seriously.
Locally, there was a public health participatory appraisal, and what people were saying was, we're not hard to reach. You need to come to us. You need to start providing provision for younger people and start looking at support for the whole family. Can you give me a service where someone comes along with me to Asda's or Tesco's to help me understand the labels, understand what's healthy and cheap, because often people are on very low budgets, and that's the kind of support people want. Often the mums were saying, oh, my parents had diabetic, but what really prompted me to change my diet and my habits and the way I cook is when I had my daughter or my son. And so we need to identify what motivates people to change behaviour and use that as an opportunity. We assume behaviour change is so easy for our patients that we can put it on a prescription and they'll go and do it. If we can't do it, and we're intelligent, educated people entrenched in this environment, I'm not assuming that our population isn't any of those things. If we can't do it, then it will be much harder for people with much more challenging environment. I'm conscious that the more of this kind of very supportive interventions that we provide, that there's a risk we're creating a dependency culture. So with all my providers, I'm saying that you need to think about the exit strategy. You need to think about the throughput, that you're not seeing the same people repeatedly over and over. We've got nearly 14,000 diabetics alone in Tower Hamlets. If you're only serving 100 of those, there's 13,900 or so that you're not seeing, and those people need your help too.
I think in terms of the NHS side, I think they've really got to grips with this idea that faith and community leaders are really important players in all of this, and so they've engaged with them really well. They've supported us to provide training, and it's kind of ongoing as well, so we're continuing to do work. So when we were doing dementia work, groups said to us, will you come back and talk about, and they listed a number of other issues they wanted to talk about, anxiety and various other things, and we were able to do that in discussion with the commissioners, so it's kind of a rolling programme.